I love this topic that we're going to dive in on. It's really, and I said this to our clinicians inside a Confident Clinician last month, it's really sort of like the meta of us looking at this topic. So I'm going to talk about through some like practical applications for you and how you can look at your own burnout and your own relationship with work, while at the same time, we're going to talk about how you might incorporate or include some of these pieces in your patient care. So it's one of those things where the highest percentage of burnout we see is actually in healthcare workers. It is a definition that is developed around workplace challenge, and it's a workplace diagnosis. We see it the most in healthcare practitioners. However, we also will experience patients who maybe have either caregiver burnout or may suffer from burnout in their workplace, and understanding how to manage it from like a clinical perspective is really important. So we're going to do kind of this both, like this is where it might be you, this is where you might see it in your patients, and how to navigate the assessment, and then also the coaching that needs to accompany the support of people with burnout. Because although we wish there was, a silver bullet supplement to cure our burnout, that's really not where the evidence lies. And it actually comes from coaching and reevaluating some of our work relationships and our work, sort of output. So it was a great introduction there. I don't need to spend more time on this, but my biggest thing that I like to share in my own introduction is my conflicts of interests, of course. And so my background is in critical appraisal. So when I say to clinicians, not every study that's published belongs in medicine, we're all very quick to agree that that's true, right? We'll be like, of course. Sometimes there's terrible studies published and we would never change our mind based on those studies. And so we can all agree on that. The challenging part is that we probably disagree on which studies belong in medicine. And so my background is in that translation from research to practice, and how to decide if clinical research actually is weighty enough to change clinical care for clinicians. And so we've built a platform and framework for clinical decision-making for integrative practitioners and naturopathic doctors, which is my conflict of interest. I will say, though, that the Confident Clinician is the only continuing education in North America that is not industry funded. So we like to stay really agnostic around things like brand and help support clinicians in making decisions that's irrespective of industry funding. So we're going to talk about burnout. Like I said, today is a little bit of a meta. You're going to hear yourself and your own work experiences in part of the discussion today. But then you also are maybe going to see some opportunities where you want to pull some of these resources and solutions into your own practice. I'm always mindful when I'm teaching clinicians about a topic that is common in them, that we have to be mindful and aware that, again, we said this in the opening credits there, that this doesn't substitute you getting support for your own health and well-being. And if you are hearing yourself in this conversation, that's an invitation for you to get support from your healthcare provider. I also, when I talk about this particular topic with clinicians, always want to remind us that coaching and the help and support with behavior change and making those sustainable pattern changes in patients is actually part of our responsibility as clinicians. So even though we love integrative medicine and naturopathic medicine, sometimes we can fall into some of the same prescribing habits as conventional care, right? Oh, you're here for the thing, here's the thing that you take for it. Oh, you're here for this thing, here's the nutrition plan you take for it. When really coaching your patient along through behavior change is most often done with their integrative practitioner. You have the time, you are an expert in behavior change. This is an opportunity for you to be able to support them, not just in recognizing what needs to be done for their burnout, but actually holding space for them to be able to change it. So when I talk about some of these strategies and some of this communication, if I say something in a way that really connects, or you're like, I should remember that and take that little phrase and use it with my patients, that's my intent, right? My intent here is to help you use that sort of motivational style interviewing, or the spirit of motivational interviewing with your patients, to help them be reflective on their work relationship, for you to do the same, and also to coach themselves or yourself towards better feelings around burnout. So the differential diagnosis for burnout, which we're going to talk about that, we're going to talk about testing before we dive into some of the theories and constructs around burnout. But essentially, burnout is tough to assess because many of the symptoms related to it are a little bit ambiguous, right? Like if we have patients that come to us with a primary concern of fatigue, like we have to like roll our sleeves up and get ready to be a serious detective because almost every health condition under the sun has a side effect or a primary symptom of fatigue. And when we talk about stress, fatigue, and burnout, it's important that we're actually assessing our patient or ourselves properly to ensure that we're actually not missing something. So it's not that burnout is a diagnosis of exclusion, but it is that it can actually mimic or mirror some of the symptoms of other chronic disease or chronic conditions that are important to co-assess or rule out when we're talking to our patients about their burnout. So fatigue, like I said, is a really difficult thing to assess because every condition has fatigue as a side effect. And stress is also difficult to assess because the stress scales, although they are validated, we're not often using them in clinical practice. We have to talk to our patients really practically about this assessment and make sure we're using the right terminology wherever possible. I'm sure you've thrown around the term burnout before, even maybe in your own vocabulary, right? Like, oh, I feel so burned out, or I'm so stressed. But when we're going to talk about these conditions, like from a medical perspective, it's really important that we actually use the right terminology because burnout is actually, a state where your brain's perception of availability of resources and capacity has changed, right? So it's essentially that your brain doesn't feel that it has the resources available to it, energy resources, the emotional resources to navigate the demands of the day, which is different than just being frustrated that you had a tough week, right? That's a very different experience. So a great way to start assessing the fatigue, and I'm not going to read every bullet on every slide. I gave them to you so you have them to read through later, is we always have to ask our patients whether or not they've done the things that would typically resolve fatigue, right? We've all had those patients where they're exhausted. And then when we get down to it, we realize they sleep like an hour and a half a night. They don't actually qualify for having a diagnosis of fatigue until we've tried to restore the things or solve the things that normally resolve fatigue, right? If you sleep 1 hour a night, we know why you're fatigued. So I put those pieces there for you at the bottom, that if patients are still fatigued after doing the usual strategies to restore fatigue, including rest, and they're still fatigued, that's when we're going to carry that forward and say, okay, there's something else going on, right? It's not just something in your day-to-day or behavior that's affecting your fatigue. So like I said, most medical conditions will have fatigue as a side effect or as a primary symptom. These are your potential differential diagnoses to try and rule out. Now, even when your patient comes in with what's suspected burnout, it is important that we are ensuring that there isn't this other co-diagnosis or other thing that's going on that might be worsening their burnout or is independent of their burnout, but there are some overlapping symptoms. We certainly have a difficult time that I'm just going to jump over. I gave you the brief fatigue inventory there to use with your patients, but we do have a bit of a difficult time measuring aspects of fatigue and burnout in clinical practice unless we're going to use some of these more validated scales. So I gave you the brief fatigue inventory, which is an easy one. It's trying to help you understand whether or not your patient has more or less energy than the average person or more or less energy than they did in the past. We do struggle with burnout given that there is some overlap in the way that we define burnout and other mental health diagnoses like depression. And there are some papers that have shown that it's really challenging for clinicians to even correctly identify patients as falling into one or the other camp. And there is a suspicion that both of them belong together in the discussion. But burnout really is a physiological state or syndrome that's characterized by emotional exhaustion, depersonalization, and a reduced sense of professional efficacy, and it's most often showing up in caregivers. Depersonalization, an example of that is saying something to your front desk like, that diabetic patient I just saw needs some berberine on their way out, right? Like we get disconnected from the people, from the value, from our life purpose. Whereas to not depersonalize or to personalize your work, you would say, Mrs. Smith or Julie needs some berberine on her way out. And so we get deconnected with the actual humans that we have in our work life as part of that burnout because we're losing that sense of purpose and sense of connection. So there are validated scales for burnout. I gave you 2 examples there of them. But even asking if you feel burned out in your work is relatively well validated. Or at least it's a good enough starting point that we maybe wouldn't delay supporting someone if they say they're burned out in their work. And if people say that they're burned out more often than 1 time per week, then we are considering them to kind of meet that diagnostic criteria for burnout. I do have a couple of pieces in here for you to just read later and consider when you're using this to work with your patients. But we have to remember when we're interviewing our patients, or even remember the way we think about work ourselves, is that quite often we will emphasize our own negative feelings about work to maintain appearances. There are some cultural differences in the way that people interact with their jobs and with their work, how they view productivity. And so the patient may say they're fine, everything's normal, but culturally, like you would go to work if you were like bleeding out the side of your head, right? And we need to ensure that we're deeply understanding our patients actually being forthcoming with the way that they feel about their work. Patients are not often willing to put up their hand to say, I'm having a hard time at work, because there's the potential that they're going to be perceived negatively or maybe have even negative consequences if they say that they're burned out. So it's important that we pay attention to this when we're asking ourselves or asking our patients, are there traits or are there cultural differences that mean that people are going to answer some of these burnout questionnaires in a particular way? And they actually may be suffering from burnout, even if they haven't sort of yet identified it. Where we struggle is looking at biomarkers. And so we're going to talk a little bit about where to use cortisol testing and if that's even relevant as part of that initial diagnosis of burnout. But we struggle with measuring some of the biomarkers related to burnout because of inconsistencies in the lab test. So where we definitely benefit from testing is in some of those rule outs, right? So does my patient have anemia? Does my patient have B12 deficiency? Those are important lab tests. But when we're measuring burnout, if a patient's cortisol comes back normal, but their burnout inventory says they're struggling, we believe what they say. We're not going to base their treatment based off their lab work. And I'll show you a chart about that in a couple of slides. So we do have to think about, sort of what are we trying to measure in our patient, and is the thing that we're measuring actually giving us the clearest picture around whether or not they're struggling with burnout. But really, when we start to think about from a coaching perspective, and I want you to think about your own work as a healthcare practitioner, there are many different social constructs for how burnout happens and what is burnout is influencing or what has influenced your burnout. So certainly we struggle when there are thanklessness in work or people feel like their work effort is not rewarded. And that doesn't always mean financially rewarded. But when we don't have positive accolades for the work that we do, or it feels like there's a big imbalance, right? Like I went to school for a long time and I worked on this treatment plan for a long time and my patient still is, not happy about it. That kind of disconnect between the effort and the risk and all the things that you put into your work, and then the thanklessness or the negativity that you face on the other side of it, which is very common in healthcare. Let's be real, we meet people in their darkest moments, right? And they're not always capable or able to give the level of thanks and gratitude to their healthcare team that maybe is deserved, that starts to create sort of a chasm for how we feel about our work and then our work output. We also struggle when there are organizational challenges in our work or we lack autonomy in our work. And really, burnout is actually an organizational issue, meaning it's not any individual's fault when there is burnout in a workplace. It's actually built through the systems that the individual has to work with. So when we talk through some of the solutions, we focus on the individuals as part of the solutions in this talk. But if you are responsible for workplace culture or workplace organization for other people, it's a good food for thought that it's actually an organizational thing that influences how workers feel from a burnout perspective. So, for example, we may have, structural concerns in your work, say like scope challenges, or maybe there's regulatory challenges. Maybe you work in a hospital setting and you're told when to come and what to wear and when you're allowed to go to the bathroom. All of those things actually sort of erode or eat away at our brain's feelings of resiliency. when we don't feel autonomous, when we don't feel choice, when we don't feel progress, when we don't feel gratitude from others in the work that we're doing, it starts to make our brain feel under-resourced and not filled up, figuratively. And that's partly what creates that feeling of exhaustion, the depersonalization, and the lack of purpose in your work. But you can see really for healthcare, regardless of which social construct we look at with which lens, you can see that healthcare is like a glaring red flag in almost any of these categories. And so it's important when we start to think about supporting clinicians with their burnout that we're actually trying to tackle it from multiple perspectives and give you the support that's going to meet the demands that you have in each of those categories. So I have a couple of other sort of differential diagnosis slides in here for you, but certainly we struggle to separate burnout and depression. We do see lots of overlap between those two, so we have to consider it as part of the diagnosis when patients are struggling with burnout. And then another interesting perspective is to question whether or not it's boredom. So there's really interesting research on boredom and what happens in the brain when we are bored, and this uncoupling from interest and personal resources in the brain and output. It's a really sort of fascinating phenomenon that happens when people are bored. But when we lack meaning making in our work, and that's not necessarily because the job is rote and repetitive, right? We always imagine, I think when we think boredom, we think of a factory line where you're stamping something over and over again. That's not the only requisite for boredom. We can also struggle with boredom when our work is so complicated that it's hard to get connected to it, right? Or something so overwhelming that we kind of check out figuratively. We can lose the meaning making in our work when our work is complex. And so it's also a potential for healthcare practitioners that perhaps they're not burned out, but that their brain has a difficult time creating meaning making from their work because of how complex and overwhelming it is, which I just think is fascinating. So I have to throw a slide in about boredom. And those are good questions for your patients too. It's where in your life is there meaning making? And for many patients, they lack meaning making in lots of areas of their work. They don't see where they can progress in their work. They don't have a lot of meaning making activities outside of work. They don't have hobbies, right? They have lots of chores and then they have work. And so it's a great question to help them understand the cause of their fatigue or brain fog. If they don't have a lot of purpose-driven activities in their work, we want to help them be able to build a list of those purposeful activities. So with cortisol, and we talk about testing, the big question here is always compared to what? So a single reading of cortisol is really not helpful. It's not like a light switch type lab test where, yes, it's deficient. Yes, it's, past the line we care to see. We definitely struggle because it's not a dichotomous lab test. And some of them are, right? Over this line, it's a problem. Over this line, it's toxic. Under this line, it's deficient. Lots of labs have some dichotomy associated with them. Whereas with cortisol, unless we're talking about the extremes with Addison's and Cushing's, we're often talking about the variations on a normal scale, right? Patients are a variation of normal most of the time. The other challenge we have is the diurnal release of cortisol. So it varies throughout the day. And we also have individual changes to cortisol over periods of time. We also have individual states in our past that have maybe influenced the way that our cortisol gets released. So for example, patients who have adverse childhood events have maybe a different cortisol pattern or release than people who do not. The other challenge is that two people who had adverse childhood events also have different cortisol patterns from each other. So we have this real hard time of comparing someone's cortisol to other people's cortisol. Where it perhaps gets curious is if we had many, many readings on the same patient over time, that perhaps we could start to draw some conclusions. But overall, we struggle because of the term habituation. So when we look at stressors, and so if I pushed all of you up on stage and made you give a presentation right now, for some of you, your cortisol would go up. You're like, Jordan, that's my worst nightmare. And your cortisol would go up, right? If we pushed you, if we changed the screen share and now it's you and you're going to give the talk, your cortisol would rise. However, If we showed up here tomorrow, like same bat time, same bat channel, and I pushed you up on stage again, the majority of you would have habituated to the stressor. So if we repeated the stress tomorrow, your cortisol would actually be lower than if we did it today, right? You habituate to the stress, and it's that acute stressor. You repeated it. Your brain's like, oh, we did this yesterday. And you accommodate by releasing less cortisol the following day under the same circumstance. The problem is that lots of people don't habituate to acute stressors. And so for some of you, we push you up on stage and your cortisol looks exactly the same. You do not habituate to the acute stressor, and it looks exactly the same tomorrow as it did today, and it may the next day as well. And we are getting clearer on some of the things that help or hinder that habituation process. And I have a few of them there. But in theory, your personal background and experiences and your underlying mental health, there's many things that influence what your cortisol looks like if we push you up on stage multiple days in a row. So you can see why this makes it so challenging to use this as a lab test, because how are we supposed to decide if you have the right cortisol or not if it's changing every day? And for some of us, it habituates to acute stressors. And for some of us, it does not habituate to acute stressors. You can see why it makes it challenging to use this as a diagnostic test for something like burnout. It may be curious for us to understand or see someone's cortisol, but it's hard for us to put a lot of weight on it in terms of how we treat. We're going to use our treatment tools based on how patients feel versus based on what comes up from their cortisol. So this is an example. This is a great paper, this Barthel paper. Essentially, they looked at many studies that looked at plasma and salivary cortisol to figure out how many people actually habituated. The challenge is that some studies took cortisol readings at 7, some took it at 8, some took it at 10, some took it at 4 in the afternoon. So trying to understand and pool all of that data was really difficult. But this gives you an idea of some patients are habituated, some patients get sensitized. And so if we make you do a presentation, you're even more cortisol tomorrow than you did today. So all this to say, as a diagnostic assessment for burnout is not particularly helpful because of the variation in it. And patients will often ask to get their cortisol tested when they're stressed. It's almost like they want validation for the way that they feel. And it's our job as clinicians to say, look, you're going to be somewhere on that normal curve. If we assess this, ruling out, the extremes, we need to base this on how you feel. How you feel is incredibly well validated here. We don't need a biomarker to confirm that you're burned out. If you haven't spent time looking at or reading about allostatic load, this is such a lovely topic, and it really helps us understand why patients have different responses to the same circumstances. So why, if we stand all of us up, do some of us struggle with public speaking from a stress response perspective? Why do some athletes at the Olympics lose their period and some don't? It's all built on the theories around allostatic load. And we want organisms or people to be resilient to the stressors that they face from day to day. As their resiliency lowers and they struggle with bearing the load of the day, whatever it is, it doesn't matter if it's going to Costco or writing your thesis. The stressor doesn't matter. It's actually about the capacity and resiliency of the organism that matters, okay? So when patients are exposed to high grades of stress and stress that's stressful for them, it can impact their brain's capacity and the way that their brain perceives its own capability for leaning into the day, right? And this is how I would describe it to patients and how I would think about it even for yourself, is that when we have long periods of prolonged stress, so the cortisol example I gave you was an acute stressor, that's not really the problem. Acute stressors are not the problem. It's prolonged stress that actually creates those changes that cause stress-induced disease and, systemic changes and inflammation, etc. But also that long-term allostatic load is what creates the disconnect for your brain. And for your brain to start to feel some of those central symptoms, like central fatigue, that's related to burnout. So there's been this long suspicion that allostatic load, resiliency, and burnout all belong together in the same conversation. You can see they're kind of all dancing around the same conversation about the resiliency and capacity of the organism faced with the level of stressor and the chronicity of the stressor. the impact that that has on how we feel from day to day. So there are some lab tests that have tried to look at allostatic load. We know that there's higher inflammation. We know that but it's really in its infancy. I'm sure one day we will see, a lab panel for allostatic load assessment, but it doesn't exist at this point in time. I gave you some of the lab tests on one of the other slides. So one of the things I want you to think about as we start to think about tools and strategies and resiliency is around how safe it is for people to even start to question their own relationship with their work, right? And as you build a safe space for your patients to have this conversation, we have to remember that it is not always safe. And the term we use in the burnout literature is psychological safety. It's not always safe for patients to voice their concerns about their workplace, right? It's not always possible for them to say that they're struggling without them experiencing negative consequences. And so it's important that we look at this as an element or a potential barrier for us achieving more wellness with our patient if they're not able to voice their concerns at work without a fear of losing their employment or having a reprimand that's related to them talking about the challenges that they're having. So really important. And there's some great references here that talk about it. There are certainly lots of subpopulations that even when we look at social determinants of health, there are many subpopulations and populations of workers that are unable to express the difficulties that they face in their workplace because of psychological safety. So when we start to talk about you a little bit, I always use this term in this discussion around gold stars because even though burnout is a systems thing, right? When we start to talk about the solutions for the individual, I don't want you to forget that this is actually a systems challenge. It's not a you challenge, right? As a person, we have to focus solutions often on the individual, but it's not the individual's fault that they have burnout. However, we do see certain traits and certain work relationships and we call overcommitment strategies in work where workers actually enter their role with tendencies that put them at higher risk of burnout. Again, burnout is an organizational thing. However, for many of us, we have had a lot of gold stars in our life for really unhealthy behavior when it comes to work relationship, right? We often reward people for staying late. We reward people for over-delivering. We've been rewarded in our own lives for not accepting help or for not delegating away tasks. And so it's a good reminder for us to actually get connected with that feeling and where we over-deliver or overcommit in work, but yet receive a lot of positive accolades and a lot of positive reinforcement for those behaviors that we're doing. We know that when people enter a new role, they often have a honeymoon experience. Maybe we all had that when we entered healthcare. And we have a distorted lens about how the positives of a role outweigh the negatives of a role. And what that can lead to is that we tend to minimize or not look for strategies to deal with the negative parts of our role until we're so far down the burnout path because we didn't really acknowledge or realize it, right? No one told us about all the paperwork when we started healthcare. That for me, for sure, was this unaddressed or unacknowledged negative for the role where we overemphasize the value of helping people. And when we go into our role with this sort of distorted lens about how good the good is and we ignore the bad, it prevents healthcare workers from developing strategies from the beginning of their career that help prevent some of those bad things from taking over, especially when the rose-colored glasses of the good parts of a role start to evaporate or go away, right? And then you can see why our brains sort of get disconnected from work and start to struggle with meaning making if the good isn't that good and turns out the bad is actually quite significant. Whereas if we can acknowledge and look at our work with a more fulsome lens around how there are positives and negatives for every role, and we want to be strategic about how we manage the negatives in our role as healthcare providers, it can help us have a longer career life because we are acknowledging and dealing with the negatives right away. So really, when we talk about healthcare practitioners, the goal is to build resiliency. We want this for you. We want this for your patients. What resiliency is this ability to remain functional and nimble, right? And being able to pivot and recover rapidly after being exposed to a stressor. So the idea is that we want to create capacity in our brain so that whatever the day brings, whatever the punches are that get thrown, that we can roll with them both emotionally, but also energy-wise, that we have the capacity physically, the capacity emotionally to handle the stressor, right? So you could kind of imagine if someone hadn't eaten in 48 hours and then they had to go run a race and they passed out partway through, we'd be like, well, that makes sense. They don't have the physical reserves to deal with this. And yet we often, our emotional bank account or our emotional resiliency bank account is quite low. And then people go work like a 9-hour day in clinic. It's kind of the same thing, right? If you're teary before the end of your workday, you've run the race without the fuel. And so the idea is that we want to build that capacity. And the way I used to describe it to my patients is that we sleep and eat and exercise today to prepare for tomorrow, not to recover from yesterday. So quite often, the way people navigate their workload is that they work, and then they like lie on the floor and have to take time off and recover, instead of imagining that the way that we treat our brain and body today is actually getting me ready for my work day tomorrow, right? We maybe could do it the other way around when we were like in our 20s and could sleep on our friend's coffee table and then go work our landscaping jobs the next day for 10 hours in the sun, right? Very different experience. But as older adults and as we work in healthcare, we actually need to build the resiliency before the stressor happens, not the other way around. And resiliency is not fixed. It's actually something that can grow or can be depleted depending on the environment that we put someone in. And so our goal is to help give capacity for healthcare workers in as much places as possible in their work so that they can develop the cognitive flexibility and the capability to navigate the stressors from day to day. And a good way to navigate this is like to think about if you were going to go find a parking spot at Costco. Some days it's like, you get cut off 3 times and you can't find a spot, but you got the windows down, you got the music playing and you feel totally fine. And then there are other times when you're trying to find a spot and like you feel like you're going to burst into tears, right? Because you're like, oh my God, the world is out to get me. It knows that I need to go in there and get this salad spinner and this is why I'm late. And you can feel it right in your body that you don't have the resources to deal with this issue. And yet those are two, like they're the same issue, right? And under one circumstance, we feel awesome and great and we can roll with it and be like, you take that spot, I'll find another. And then in the other, exact same scenario, but yet our tolerance, capacity, resiliency is much lower and our ability to navigate that stressor is impaired, right? And that probably has shown up for you in your work and this shows up for your patients where the same circumstance is dealt with differently in your brain because of what your capacity actually looks like. So these are the things that are the biggest triggers for healthcare practitioners. We have a lack of mentorship and advancement opportunities. So counterintuitive, but actually taking advanced training and having meaning making in your professional development actually really does help reduce your risk of burnout. And mentorship is an incredibly important aspect. Right? Many of us in our role in healthcare, everyone turns and looks at us if there's a problem. And then you're like, why is everyone looking at me? I don't know how to solve this problem. Whereas if we have mentorship and have guidance and coaching in our own workplace, we generally do better or we can be more resilient in faces of stress. We sometimes lack the tools and resource that reduce our workplace demands and tasks, right? There are many tasks that can only be done by you. And some of those tasks are repetitive and there are not very many shortcuts, although we're hopeful with technology that some of these go away. We sometimes lack community and have loneliness, or there's unreasonable workplace expectations or a negative work environment, right? In general. We may have a high level of unfulfilling tasks that lack meaning making, right? Like, I don't know how meaningful it feels to write another thyroid prescription. We have to try and create meaning in it. But it's common that some of those rote and repetitive tasks feel like they have a lot of meaning making. And then sometimes we struggle with autonomy. And this is maybe more common in the conventional healthcare system. We like to think in integrative medicine, we choose our own hours, we choose what we wear to work. But sometimes we struggle with more systemic challenges that impair our autonomy or make it hard for us to make choices. So I've given you some examples for how to look at burnout and how to look at workplace strategies that support the opposite or help improve resiliency. We start to face burnout in our work. It's very common that we use what's called performance protecting strategies. So what that means is you overcompensate, right? As you're getting more stressed and burned out. And we actually try and preserve our work output, even though you're not not feeling as good. And you'll see this in your patients. All of a sudden they're working at night, or all of a sudden they're also working on the weekend, or they're skipping the team bowling at lunch because they're trying to finish their charts, or maybe you have done this. So we often decrease some of our self-preservation strategies like exercise, nutrition, right? So if you're like skipping the gym, ordering Uber Eats, and staying late at work so you can keep up the same number of charts, we're actually getting further and further down that burnout hole than if we, can acknowledge and recognize that your work output is actually going down because of how you feel. So a really interesting piece, and it's a common one, right? Like we want to maintain almost the appearance of high output at work, but the thing we do is actually can all of our strategies that help build resiliency and help keep us healthy. So I gave you some examples of some various psychological strategies that we use with patients to help them understand how they can renegotiate their relationship with work. So these are quite wordy, these slides, but it's because it gives you all sorts of strategies to use with your patients or to consider even with yourself. So we want people to reframe their goals. We want people to identify resources that they maybe haven't used in your work. And I gave you some questions here. This is what I will ask patients. I'm always amazed at the number of patients who have access to a counselor at work and never go. So I think this is really important that we think like, what are the resources that are right in front of me that I haven't actually utilized yet, right? Do we have evidence of psychological safety? Have you been given any signs that asking for help at work is not acceptable? What advice would you give a peer if they were struggling with the same work challenges you were, right? What would you say to them? Would you say, don't take your work home? Would you say, reduce your caseload? Would you say, maybe you need a VA, right? Like, what would you say to a peer? Because it's maybe the same advice you would want to give yourself. And often by giving ourselves some additional training or additional resources, we can reduce our burnout. I've worked with thousands of clinicians, and I'm always amazed that people won't take half an hour to learn how to use a feature in their own EMR that will save them thousands of hours, like starting the next day. When we get burned out, we will not put time towards personal advancement, even if we can see mathematically that personal advancement would lead to better work on the other side. It's a very difficult thing to put effort towards when you're not feeling well. But thinking about whether or not there are resources, whether that's AI charting or one-click patient protocols, which is what we do at the Confident Clinician, things that actually would support your work output and make it easier for you, but requires a little bit of time investment for you, that's an incredibly important reflection question for you to do. And I always want healthcare providers to exercise autonomy wherever possible. So maybe you wear something, that's comfortable at work, or you choose when you're going to have your lunch break that's the best for you. Maybe choose to work one virtual day. Something that creates the feeling of autonomy and choice is incredibly important. I gave you some specific suggestions for healthcare workers that will really support you in thinking about your own burnout. So project planning, your goals, making sure that you're thinking about your work in the most positive way possible. And I don't mean toxic positivity. I mean that the more burned out we get, the more disconnected we get with the value of the work that you're doing. So it's common when we're feeling burned out or feeling behind that we'll say things like, I have to get these charts done or my patients are going to think, I'm an idiot or I'm not very professional, versus having our automatic thoughts be, I can't wait to get these patient charts done because I'm going to have such a big impact on their lives, right? We want to change and create that meaning making in the work that we're doing so that we can actually feel more connected to the tasks and actually see the value in what we're doing, even if we have to create it for ourselves. I gave you a bunch of other examples here. So is there technology or mentorship or solutions in your workplace that you haven't yet accessed that you could? Is there a spot where you can make an investment, whether that's a VA, whether that's new technology, whether that's support that would actually help your workplace be more smooth and help your workflow be more smooth? Those are a couple of great examples for that we can do with our patients or we can do with ourselves. The last thing I wanted to share, and when you have this slide deck, you'll see that there's hundreds of slides in here that we're not going through. And it's more because my MO is to over deliver on the information and then us have a really good conversation about it. The one thing I do want to call our attention to is just how impactful the positive psychology interventions are. So I always ask, anyone have one of these, right? Did you ever have one of these? diaries. I did. And the only time I wrote in it was when I was mad at my parents or boys. This is what you wrote in your journal. It was like when you were mad or when there was a boy. The evidence, and I've given it to you on another slide, is that when we encourage clinicians to have a rigorous and routine gratitude practice, when we cultivate the feeling of awe, or when we help healthcare practitioners practice 3 good things, so write down 3 good things that happened in your day, the evidence is very strong that we can start to reduce fatigue, reduce depression, and improve resiliency in healthcare professionals. So that idea of those positive psychology interventions, which is gratitude journaling, cultivating, has been demonstrated in the research in lots of different ways. Taking photos and writing about them, taking photos and then even having them as a background on your phone or a background on your computer, taking time in nature, sitting in nature. All of these things do create that feeling of awe in the brain and creates that level of resiliency and support. And the 3 good things was an exercise that was done in a few different healthcare settings where they forced the physicians to write down 3 good things that had happened in their day. And by doing so, and I have the evidence for them here on the 3 good things, I gave you all of the studies so that you could look at them. In these ones, I gave you what they actually went through in each of the sessions with the healthcare providers. And I gave you this because if you're working with patients who have burnout, this is a great way to structure your appointments with them. Right? In session 1, this is what we're going to talk about. When I see you next, this is what we're going to talk about when I see you next. So I gave you a bunch of those studies that actually show how to pull burnout treatment into your patient and your practice. I also gave you a few slides here on nutrition and exercise. And the short answer is that there are no nutritional interventions and no specific exercise that worsens burnout or worsens cortisol, right? We would do the same things for patients or ourselves with burnout as we would anyone else. Where we maybe see this slight change is that if someone never, ever, ever drinks caffeine and we give them a cup of coffee, we can raise their cortisol. But for everybody else who drinks coffee on a regular basis like I do, coffee does not have any negative impacts on a cortisol release. And so when we're building that long-term treatment plan for ourselves or for our patients, we want to pull in everything else we know about health. Right? Good diagnostics, good balanced nutrition, good balanced exercise recommendations. But where it really comes down to with burnout is talking to people about what's happening in their workday. Can we build capacity and resiliency through modifying the way that they show up at work or how they feel about their work? I always ask my patients, I'm like, do you know what a B+ looks like? Like doing a B+ every day is better than doing an A+ for 3 months and then having to take sick leave. So can we renegotiate what that work output looks like to be able to support long-term strategies in the workplace rather than us doing that sort of sprint and fall kind of pattern that patients are often, do when we first meet with them. And then making sure that we are accessing all of the resources that are available to us or being really radical with what parts of our work do need support so that we can help create more meaning making for ourselves as healthcare practitioners.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.